spotted malignancy?
Of you having a good relationship and having seen your doctor every 6 months, every year, if you've any problems. And you know, there's 5 bone tumour units as an adult in the UK, and they're the 5 you should be seen probably at one of those 5 units. Are you being seen attending one of those 5 units?
We have been. It's just sometimes there's a lot of variation in how often you should be having scans, or how, you know.
I think that's what we were talking about we were talking about earlier, that there is no protocol which is set as this is the best system. And maybe that's what, by working on it as a network and with larger communities, we could come to a better, more established protocol. But it will also vary from individual to individual. So having a good relationship, long-term relationship with your doctor, I think could be very valuable. Was that your doctor?
Can I just check again what those 5 specialist centres are?
The 5 bone tumour centres for adults are the Royal National Orthopaedic Hospital in Stanmore, the Royal Orthopaedic Hospital in Birmingham, Oxford, the Robert Jones Agnes Hunt in Oswestry, and Newcastle.
Thank you.
But paediatrics will be many paediatric units, yeah. Hello.
Sorry, can I just ask, in your surveillance of adults, are you looking at genetic testing in just the cartilaginous tumours that are removed, or are you looking at other tumours that are removed from the Olios patients?
We're looking at anybody with cartilaginous tumours, so it's very much a cartilaginous tumour project that we're looking at the moment.
Right. So, for example, my brother's just had a brain tumour removed, which tested positive for the IDH1. So that wouldn't be a tumour that you would be looking at?
No, except that I presume, am I correct in thinking he also has cartilaginous tumours?
Yes, lots of them.
Well, therefore, if he could have been included, or he could be included in that study, and clearly then we would also, when we're interviewing, know him with any other issues. But the reason we've focused it around the cartilage is because virtually everybody has the cartilage tumour. A minority of patients have other tumours, yeah, but then you capture everybody.
Yeah.
Yeah.
Just one more question, please.
Sure.
Your UK
You have to,
study,
you
is
come
it-
all the way from Australia.
Yeah, we did, yeah. My just one very quick question, the UK study, does it have to be UK residents or can it be outside of the country?
Well,
Like
it's
me, for instance.
well, we'd be very happy to include you. I mean, I know people in Sydney who could, but I'm sure that they could do it, or we could talk, or you could
So
send
where
it
do
right
I,
across.
you
You could email me.
okay,
Yeah.
I can get those before you leave today, is it?
Yeah, or
Or
Charlotte
via
has
me.
mine.
Yeah,
Yeah.
okay, no worries, thank you, that's it.
Well, we're taking up good time of somebody else has much more information to give you.
Thank you very much. Very, very educational talk, actually. So my name is Farhan Ali. I am from Manchester, and that's my talk. It's a born doctor's sort of talk. So there's something to be said about orthopaedic surgeons. Well, that's my hospital. It's a children's hospital in Manchester. The new building, the new site started in 2009, and that bit is sort of Greater Manchester, somewhere there, so for people who maybe from abroad. So Manchester, well, that's what we have: football teams and curling iron. So yeah, I'm not taking sides here. One of the teams doing much better this year. And talking about orthopaedic surgeons, so we are actually but of sort of a lot of medical jokes, and there's a reason for it, I think, because you know I don't know whether that comes out very clear, but essentially an orthopaedic surgeon will get the head in to stop the lift door rather than hand, because you use your hands, not your brain. There's another one. Internet's full of orthopaedic jokes. so there you are. So and orthopaedic surgeons actually, you know, we did a proper research, and this was published in the BMJ Christmas edition, basically saying that, you know what, we are strong and clever, so get back on their knees to this, really. Anyway, let's okay, so this is the sort of work I do. My practice is mainly pediatrics, and it involves limb reconstruction, and that's the reason I get involved with looking after children with Olliers and Maffucci, multiple enchondromas. So really, I think this talk will just go through sort of background, clinical features, diagnosis. I think most of it has already been covered. Management and maybe some future directions. So really, it is a varied condition. There's a huge spectrum, and it's quite rare. And enchondromas really are, you know, clumps of cartilage within the bone, and it could be solitary. In this case, it is multiple. And this is a famous guy who's given the name. He was a professor of surgery in Lyon, and he pioneered several sort of bone grafting techniques, skin grafting techniques, and he was awarded Legion of Honor by the president at that time, President Carrot. I think the day he was given that medal, that's his medal, the president was stabbed, assassinated, and he was the surgeon in charge, so he had to treat him, and obviously didn't say, well, that's a bit of trivia on Dr. Ollier. And Maffucci, sorry, actually just Maffucci, he was a professor of pathology in Italy, and his other claim to fame is isolating bacteria for tuberculosis in birds. Well, so this is the sort of slide which I think we mentioned before, that, you know, you have multiple enchondromas, but, sorry, you can't see it there, but the Olliers, so Olliers and Maffucci's are the most common of this rare bunch. And they are the ones which are non-hereditary, but there are others which sometimes can get confused, which form, you know, which may have a hereditary component, but as far as Ollier and Maffucci is concerned, that is non-hereditary. I think that's the key bit here. Right, so I've said exactly the same thing. I don't want to repeat it. Non-hereditary and mosaicism. So some cells are abnormal, some cells are sort of not working properly. Very rare. I don't know how accurate this figure is. I mean, we say 1 in 100,000. But I don't know whether somebody's actually really done a proper look at it. I've read somewhere there are only 200 cases of Maffucci's described in literature, so which is quite rare. Now, the bony involvement are similar in both conditions, and really it involves multiple cartilage lesions in the bone, which are asymmetric in this distribution. So even if it's bilateral, it'll have one side which is more sort of severely affected. And it affects different parts of the bone. Most commonly in the long bones, you have the ends of the bone which funnels into, so the funnel bit is known as the metaphysis, and the cylindrical bit is the diaphysis. So it affects mainly the metaphysis, but it can also go into diaphysis. And it affects your flat bones as well as long bones. So flat bones are, in the middle, and your appendages, your appendicular skeleton is your long bones. And really, I think Maffucci is really, you've got an addition of soft tissue hemangiomas, lymphedema, and other soft tissue abnormalities. So the skeletal problem is more or less the same. Well, that's what we think at the moment. So really, what causes it? I think this was again very nicely covered, but I think we're not 100%. There are indications where we are, but there may be more than one thing here. And really, it is there's a problem in how this cartilage cell is maturing and proliferating. There's some sort of feedback loop that's not happening where it has to stop, it's not stopping, it's not maturing into bone. And you mentioned about IDH1, IDH2, and there is some suggestion of, in Olliers, there's another, another sort of component, which is parathyroid hormone receptor propagation mutation, which again is only 10%, so it's not all that common. So I thought I'd just put this slide as sort of for bone development. And really, I think, the initial bits of, clumps of 1, 2 cells and 4 cells, eventually at around between 4 to 6 weeks, they clump together to form cartilage. So this is the initial bit of cartilage, and it forms some sort of a tubular shape of a bone. The central bit starts thickening up, and it forms a covering known as the periosteum. The bit in the middle, the cartilage in the middle, then starts to sort of hypertrophy, so it gets bigger and gets calcified. And at the similar time, you have the cells on the outer layer of the bone producing osteoblasts, which would essentially which start producing bone.
Mm-hmm.
And they sort of, encouraged by the blood supply, go in, and the osteoblasts come in, and they then absorb along, they've got the cell along with the cells which absorb all the calcium and then lay down the bone. So it's just not calcifying the cartilage, it's basically removing the whole structure and then laying down bone. So it's almost, you've done one work, which, put the wall up, but you're taking all the plastering away and then putting a new, so that's what's happening. So you've got the structure, but you're laying the whole thing again. And that's what causes bone, and then the medullary cavity forms, and you have the two ends of the long bone, where the secondary ossification centers open. So exactly similar method, but you have a primary ossification center in the middle, and then you have secondary ossification centers on either end of the long bone. Now, sandwiched between the two will be the growth plate, which remains unossified till your skeletal maturity, which can be anything between 14 till 18 years of age. Now that's the bit which continues to grow. Sorry, are you going to ask something?
Yeah, I was just, so it sounds like it's part of growth, but then the next thing is how does it keeps happening by the sounds of it during adult life as well.
So it's probably happened, like Professor was mentioning, very early at life, and it's just that's what's developing. So the cells that are going to form bone are already there. So the next slide will show, I don't know, yeah, so that's the sort of cross section of a growth plate. I think it's probably more clear here. The top layer is just under the top layer here. Yeah, the top layer here is called the reserve zone. So all the cartilage that you need to form bone is already there. So all the cells. So that just forms once. It's like, number of, ovarian cells, or, all those are sort of standard number. And as you continue to grow, they start maturing, sort of, proliferating and then becoming into the final, bone. And that creates, so the original cells are already there. So the original cells at the top are already there. And then what happens is they start multiplying and then becoming fat, and then at some point they decide, we need to become bone. And the process of this is known as endochondral ossification. That's what gives you, a cartilage template, which then gets replaced by bony. And this is the sort of a negative feedback loop which is happening between this. So there's a tight control here, so how and when this cartilage becomes bone. And obviously, as it was nicely demonstrated by the last talk, how, with IDH1 mutation, you can actually have this enchondroma then sort of forming. Another important thing is that when children break bone, a lot of fractures happen through the growth plates. So growth plate is quite thick here, but it's actually, a few millimeters only. Most of the fractures actually happen through here, which is the proliferative and the hypertrophic zone. So if you damage that bit, it doesn't actually, everything heals and cartilage, the growth plate starts to grow. It's only when the reserve zone gets damaged, so if there's an injury which is going into the joint, so which fractures from one end and goes into the joint, so it's actually gone through the growth plate, or if there's anything like a big pressure area or even surgery or anything which actually damages the reserve zone, that's when the problems happen with growth. Because if you take that reserve zone off, that bit is not going to grow. So that's the bit to remember, because children do get problems of growth and in terms of deformity. Well, clinical features. So majority of people will present. There are several ways one may present. I think the commonest one is palpable swellings, particularly hand, feet, and one thing leads to the other. Then the other way you would be is, either you have a deformity in the leg, how you walk, one leg slightly shorter than the other. So those things get picked up. So those are the ways somebody might present. Fractures, another way, is everything's been fine and suddenly you've had an event in a playground, you end up and somebody does an x-ray, there's a fracture, hang on, but there's something else going on here. And it's a pathological fracture, and that sort of leads to sort of ultimate diagnosis after that. And sometimes it is the skin lesions, it's the skin lesion or the soft tissue problems which then start the whole process about is there something else going on here. Now, in itself, sort of, pain is not a common symptom in childhood, but you can, and I think pain, if it is there, then one needs to sort of look at, is there anything else going on? Most commonly in children is either there's a fracture or impending fracture. Most of that pain is not rest pain. It happens on mechanical pain. So you're doing something and it starts to hurt. Whereas in an adult, if there is pain, particularly rest pain, that needs to be investigated, because then you're worried about, is there something else going on?
Excuse me.
Hi.
Don't particularly agree with what you just said about
Okay.
pain, because understand I'm in the 17th, so I don't know much about it, but like I personally experience pain quite constantly, and I'm pretty sure I only have 4 years in the food sheet. And in general, when tumors grow or when they start to appear, I feel pain, no matter if I move or not. And also pain after I walk, like that's probably the worst.
Yeah.
So
Do you get looked at when that happens?
yeah, I get checked really often.
No, that's right. So I think that's exactly what it is. So when pain happens, you don't sit and ignore it. When there is pain, you get it seen to. But is it painful all the time, or is it?
But I don't think that pain is usually related to, for example, a fracture. Like I've had that, but it's like, for example, right now I can tell you that my knee hurts, and I'm not moving, I'm not doing anything. It just hurts, and I know that stuff is happening.
Yeah.
So.
No, I completely agree. So I think, and yes, I do see children who have pain, but I think
what she's trying to do, I'm sorry, but pain is part of the disease.
yes.
Constant pain, and especially during the night, that's unusual. But pain is part of the disease. I've seen her suffering.
No, so I'm not trying to
always.
underestimate the burden of the problem, but what I'm trying to say is the importance of getting things checked. Because what I'm saying is it's a symptom that you don't want to ignore at all. Just because you think I get pain all the time, it's not a symptom you want to ignore, because there is nothing else that sort of to tell you that I need to get it checked. If there is, for example, you have a threshold of I feel this is my daily event, and you've seen people, you've been thoroughly checked and everything's okay, that's fine. Then you're monitoring your own level. But what you don't want to do is just say it's happened, but it must be this. But what I'm trying to say, I'm not underestimating what you're going through. What I'm saying is, pain is something which you don't want to ignore. It needs looking at. And once everything's clear, that's fine. It's not fine for you. I mean, you need to get on top of your pain. But at least things have been looked at, and and that's what I'm trying to say. So pain, when I say is unusual, it means that that's what if it's not something that you ignore, then if it is there, it needs to be looked at. You need to rule out any pathological reason for pain. Okay?
Sorry. Hi. Sorry. I totally take on board what you're saying there as
Yeah.
regards if there's unusual pain, get it checked out. My son is 11 and he's recently started complaining about pain in his fingers. And I thought maybe he'd injured them and I needed to get it checked. But he was saying that he's getting pain in both of his hands at the sites. And I was wondering, is there something, because I'm just asking about the bone development, is there anything during puberty that could be affecting the incondylomas that could be prompting that kind of?
There's possibly. I mean, I'm not aware that actually, the growth hormones will actually make it bigger. Possibly there is some effect. I think these are the things which probably needs more work and looking at. In terms of the activity of this benign tumor during certain hormonal phases, I don't know. I mean, whether it may be worthwhile. These are things to look at in terms of is it sort of worse at certain time of the year, and whether certain periods in terms of when you are shooting up, you become getting a growth spurt, whether that's that's changing the way your symptoms are. But does the other hand have
Yes.
incontinence?
Yeah, because when he started, he doesn't really complain about pain, but I've heard of it through other people
Yeah.
that have experienced it. So I thought, well, hang on, maybe this is starting. But given that it's his hand, and he's a boy, he's an active boy, I thought maybe he might have injured it. So I was asking him about it, but it's actually in each of the sites across both hands that he has the condomas in.
Okay.
That he was feeling pain, which I thought was it was unusual.
So generally, when this happens, so if you come and see me, the least I'll do is get an MR scan of this, and because that's the best way to look at if there is weakness of the bone, whether there is, an impending fracture, if especially if the lesion is on both hands. If there's nothing in the hand, so for example, one hand's there's no cartilage lesion.
No, it's in both. He has cartilage lesions
No, that's right.
in both hands,
Yeah,
and it's
yeah.
at the sites of the lesions, and that's he's complaining about pain across all of his
Fingers.
all of the fingers that have the lesions in it. That's
Does
why-
he have lesions anywhere else?
Yes,
And do they hurt?
he hasn't been complaining of pain, but I try to walk the line between getting information from him and not actually kind of suggesting things.
It's a difficult. It's a really difficult one.
Mummy's expecting you to have pain everywhere.